Hello, everybody, to our countless viewers and listeners. Welcome back to another episode of Overfilled, the podcast. It's your usual crew. I'm Jason. There's Brooke. There's Jamie. And we are here to talk specialty contact lens life and the many highs and the occasional lows and the challenges. So today, once we get our overfilledness out of the way, we're going to talk myopia management, in particular, those low myopes, because we all know what to do with the high myopes, right?
Yeah.
But there's a lot of kind of options for the low myope, and we're just going to talk through these options and give our 2 cents and see where it goes. So, but first, as always, we'll talk about being overfilled. So who wants to jump in with their overfilled of this week?
I'll do it. Oh, you go.
I'll go. I don't know. I had a couple ones, but the one that I really liked the most was last week. I had a new keratoconus patient that got referred in, and she was 23, and she did not speak English. She spoke Spanish. She was from Mexico. And my friend actually referred her from a commercial location, and she came in, her husband was with her, and she was not seeing very well at all. And we were able to, even just diagnostically putting a lens on, take her from count fingers to 20/20 in the one eye. And even though there was like a language barrier between us, like just putting the lens on and seeing how happy she was and how excited she was awesome. And it was the first week for my new student, and she loved it too. And it was our last patient of the week, of her first week. And she's just like, that was amazing. I just wanted to forever. And I'm like, and this is why you do it, And like the bummer part was she had been complaining about it the last couple of years, and she had been to offices and they just said, you have amblyopia, or you just have a weak eye, or I don't know. Sometimes when there's that language barrier, especially if they're in a really high volume situation, it's kind of like, I don't know if they just don't take time to investigate. So they were just happy to have the time and to get it figured out and know that like she's not permanently doesn't have sight in that eye. So they were both like just so happy. But I know we do sclerals all the time, but that was just one of those that just stuck out in my mind that, she's so young and do cross-linking and stop it and get her to see better. And I like showing that to my students too, so they get to experience why we do what we do firsthand. So that was my overfilled. So we got to leave go out to the weekend like on a high note. So
awesome.
That's awesome. Patients, they, sometimes they like, tear up or get excited or, whatever. They respond in like a pretty emotional way. And they're like, I'm sorry, you must think that I'm just a weirdo for doing this. This is so important to me. And I always tell them that it like never gets old. Like, this is what I've been doing for 15 years. And this is why I keep doing it. It's like favorite part of my practice. And it truly never does get old. Like every tear that comes from the chair, every smile and like emotional excitement about what's to come through the fitting process. It just, like you said, it never gets old. My overfilled was that it was Hunter's birthday yesterday. And we, offered him the choice of where he wanted to go out to dinner because his birthday party with his friends is tomorrow. And tried to talk him into something a little more exciting, but it was Burger King. So he went to Burger King and he got to play on the play set, which was actually kind of nice. And it was like not very busy. And so he did that.
And he got the crown.
He did. He got
the whole reason to go to BK.
I didn't even know they had a play set in Burger King. Yeah. I have not taken my kids have never gone to Burger King.
So we've never been there either, but the Burger King, like when you turn into the kids' parking lot or into their school, you can like see Burger King kind of diagonal. And so they can see like the slide in the window. And so he's always asked to go there. And I'm like, no, we're not going to. Like if we're going to go someplace, like we're going to Chick-fil-A, at least
right.
And, but anyway, so he picked Burger King. There was no talking him out of it. Like I offered endless quarters at Space Aliens and it was a no. So Burger King we went.
Funny.
So that was our overfilled yesterday. Oh, and we took him and he picked out a new bike afterwards. So he's grown out of his little training wheel bike. So he has picked out a fun, nice red bike last night.
Very cool. All right. Well, I'll just follow on Jamie's footsteps on with a scleral lens patient, and I just had a patient I've been working with recently. I've probably been seeing him maybe 6, 7 years. Keratoconus, left eye more than right eye. Ben had tried sclerals before he came to see me and did not like them at all and did not want to go for sclerals. So, so at the time, refracting him with glasses, he got like 20/20 minus in the right eye, 20/40 in the left. So I just fitted in some soft torics, and he's been getting by like that for the last 6 years or so. But when he came in several months or a few months ago for his regular checkup, kind of just talked to him about sclerals again, and that there's new technology, there's new stuff. We have HOA correction now, and he's like, "Yeah, I'm willing to try it again. My bad past experience is far enough behind me that I'm willing to try it again." So the first thing we did was we did a scleral topography, which showed about 400 microns of toricity. So right away, now you know what I'm thinking, right? Well, the reason his last lenses sucked was because they were spherical, probably.
Right.
Maybe they were toric haptics, but not by elevation.
Right.
Okay? So put him in a diagnostic lens. Like, wow, this is way comfortable than anything I've ever tried before. Ordered him up his first set, which he came in to get last week just for dispensing, which I didn't even put on. It wasn't ideal. It was still kind of loose, and I needed to do a little tweaking. But with the lens on, he said, again, felt great. Over-refracted him, and with just some cylinder, he got to 20/20 minus without even HOAs.
Mm-hmm.
And he's just like, so do I get this on my other eye now or what, So anyway, we're going to finish the fit. I'm going to throw HOAs on him. His bad eye is going to be like 2015 probably when we're done. And his right eye will be stuck in the soft toric at 2025. So I'll have to refit that later. But the point is to all that is to say technology is evolving, even with sclerals. And so if you have a patient who's tried something in the past and it didn't work, I would say when you have a new option that comes along, don't be afraid to talk to them about trying it again. And so for this guy, again, he's going to be like, he even took the first order home with him, even though it wasn't great and it didn't have any sill in it. He's like, this is still better than my soft toric. So he's wearing that one while we're waiting for more. So I would just say, again, thinking about HOA correction options, which we have now, which are going to help people see better, better technology for getting a better fit. Just don't be afraid to reintroduce sclerals to a patient.
Definitely.
So that's cool. Anyway, so we're going to talk again myopia management, and in particular low myopia. Brooke, do you have something you want to lead us into this discussion with?
So as I alluded to this last time, Nora was complaining about her vision. In fact, she used a little coupon in school that is normally used to swap seats, to sit by a friend for the day. She decided to swap seats so she could sit at the front of the classroom. So I did a quick exam, and she ended up minus 75 in the right eye sphere, minus 1 sphere in the left eye. And so I decided, all right, it's time to get started. The day that we've been waiting for is finally here, because I'm a moderate myope and Brian's even higher than that. So we knew it was happening, and she's currently like 3/4 the way through. I think it's book 5 of Harry Potter, and she's read them in like 2 months. So she has. Thank you, Harry Potter, for my daughter's nearsightedness. And anyway, so we went to pick out some glasses, and we got some cute frames picked out. We picked out 2 of them, and I'm still kind of trying to decide what exactly to do, but we're going to do Stellist in her preferred pair. And that's what I decided to do for now, because I don't think she's ready for Ortho-K or soft lenses. She's kind of a low maintenance kiddo, and being minus 75, I feel fine with her like playing basketball and things like that. And so I'm kind of leaning away from Ortho-K and soft lenses for now. Still considering, like, is atropine in the picture or not? Or do I even start atropine on my 5-year-old or now 6-year-old who's a plus a half. So that's maybe another conversation to have too about those probably pre-myopes. Anyway, so let's talk about early myopes. So I have a 9-year-old who's roughly a -1 in both eyes. And which way are we going here? What would you guys have done with your kiddos?
So I don't know. I agree with you also with what you're doing. I think a lot of people early on, especially, were like, do ortho-K. Well, the thing with ortho-K, and you can correct me if I'm wrong, Jason, which I might be wrong, but I just felt like when you try to do ortho-K on these -1/2 or 75s, it's not enough blur. Like, it's better than nothing. I just don't think it's enough blur. And I would rather put a kid that's a low myope into either a soft lens that gives you more of that peripheral blur artificially on the front of the lens, because I just don't think it's enough. It's better than nothing, but I don't think it's enough blur to do as much management as the other options. So that's my mindset on it. If someone's a low myope like that, it's better than nothing to do ortho-K, but I think I would rather do a soft lens or glasses. I think it depends on the kid. I mean, I'm a high myope myself, and so I've been watching my girls, and my oldest is 7. And it's funny, she was just in the office with me during a snow day, and she said, "Mom, I want to wear contacts." And I said, "You don't need contacts. Like, she's like a low plus." So I think it's different. Like, if you have a kid that's like, "I want to do contacts, like I'm excited," then I would definitely do, lean into the contacts. If they're more like, not sure about it, I would start with glasses. So I think it depends on each child also. What do you think, Jason? Am I wrong about ortho-K for like a 50?
No, I think, again, a lot of times the first step in this process is to establish, does the child even need corrective lenses?
Mm-hmm.
Because that child who's a -75 in both eyes, who's like 7 years old, might be 20/25 binocularly, and they don't even need them. So then to introduce optical correction, like especially contact lenses, to someone who really doesn't even need corrective lenses, now your risk and benefit ratio is thrown off. So you say, well, I want to slow down progression of myopia. It's like, okay, I get that. But when you're dealing with the risk to benefit of progression of myopia versus, wearing ortho-K or soft lenses to try to slow that down, when the child's clearly needs corrective lenses, now all of a sudden the benefit of doing it is better than whatever risk there is for wearing contact lenses as a whole. If the kid doesn't even need contact lenses, now you're adding a risk with very little benefit.
That's a really good point.
So then it depends. It depends, right? So again, for a -1/4, -1/2, clearly I would not put them in contact lenses. -75, -1, like where Nora's at. Now we're starting to talk in a situation where, especially in someone who's 11 versus 6, right? 6-year-old in preschool or kindergarten, how good do they need to see? 11 is different. You're getting into a classroom where you have rows back, and I need to see the front of the room, and I need a corrective lens now. But again, she's not like desperate either. It's like, I need it for the classroom, but they could probably come off for playground and recess and sports and stuff. So, again, it's all, some of it is the vision correction. Some of it's the age of the kids. So again, like everything else, we really want to try to individualize it. Right. And to the child who says contacts are for me versus I can't stand the idea of touching my eye. The good news is we've got lots of options, right? We got atropine, we have glasses, now we have contact lens options. So no matter what the situation, what the kid's deal is, I think we've got an option. Now, I'm not like the type of person who's going to get hung up on that every little click of myopia is a death sentence, right? To a 8-year-old who just went from a +1/2 last year to a +1/4 this year, I really could care less. And people say, well, don't you want? No, I don't really know if I care if that kid becomes a -1/2. Again, our number one goal, is really to keep them from becoming a -6 or above.
Right.
And our next goal is just keeping them below a 26 axial length. And then our next goal of that is just the less is better. Okay. So, we all have to think about the urgency of the given situation. So all of that said, I think we know that ortho-K, I would say that the kids that I've put in ortho-K, when we started in Ortho K and they're already like a -3 or 4, they don't really progress a whole lot.
Right.
Which is crazy considering where they started. And a lot of these kids, like I can remember so many people over the years who were 6 or 7 years old, already a -4. You put them in Ortho K and they don't change for years. And you're like, you were in the hot spot of myopia progression and you didn't change. And you already were a 4 at 7 years old. Whereas I've had other kids who are like an 8 or 9 or 10-year-old who are only a -1, and you put them in Ortho K and they're progressed at half diopter a year still.
Yeah.
So I think your comment, Jamie, is spot on. It's like you just don't get enough blur, you don't get enough confusion there to make it actually have an effect. And so I love Ortho K. It's, again, what my kids did for their myopia management. But again, we got on them a little later than I probably should have. And so they started when they were a -3 and a -2. And it worked fine. And I still think it's great. Again, for that lower myope, at what point do we say, the kid like somebody is all about contact lenses, at what level of prescription and age are you comfortable putting them in a MiSight, for example? Because obviously with a MiSight, you're going to get like 2.5 diopters of blur no matter what the prescription.
Yeah.
So you're going to get the blur, you're going to get the confusion. Even if the kid's only a -1/4, they're going to get confusion like they were a 250. So you get the effect, but at what point, at what age, and at what, again, if the kid is 14 and they're a -1/4, I don't really care. If the kid is 6 and a -1/4 and mom and dad are both -7s, that's a different story, right? So at what point are you reaching for soft lenses for myopia management for these lower myopes now?
I think that's in the early myopes too, especially because you can build in that blur. With Ortho K, you can, decrease the back optical zone. You can increase the Jessen factor to try and like build in some of that extra blur. But, those low minus prescriptions in those lenses that have already proven like such good data and control, it's like, why mess with it? They really do a nice job. And again, it's patient dependent. If they're doing a lot of certain activities, maybe I lean toward Ortho K over soft lenses. But again, like knowing that the data is there versus like trying to make sure that you get the smaller OZ with the increased Jessen factor and like kind of tweaking. There's just so much data behind these soft lenses. And so I feel good about that. And another thing in like preparing for this discussion and also educating myself for Nora, they noted that, these myopia management spectacles had really good evidence against at least 0.01% atropine. I didn't find, unless I missed it, on 0.05% atropine, but knowing that, with that data that the DIMS or Stellest or whatever type lenses is good, felt good about that. And again, just Nora's personality. The second pair, I decided to do just a -1 with the transitions for outside, just in case as a backup pair, in case something happens to her Stellest. At least she still has a set of lenses to wear. They don't come in a transition right now or a tint. And so I did just a pair of glasses that will change into sunglasses. So when we're at the lake, she can still put them on and see far away if we're looking at something special. And then they also, serve as a pair of sunglasses too. So that's what I did with the second pair. But, I hope she is comfortable enough with her Stellest lens to prefer it and doesn't prefer the sun or the transition pair because of the single vision aspect of it. I may have to hide them and keep them for, those types of activities. So we'll see how that goes.
Yeah, that's the tricky part. I know in other countries you can get a transitions because I looked it up for this little boy who's 6 that I see on atropine, and he's already like a -5, -6. He's just not really ready for contacts, and he loves his transition lenses. So his mom was like, "Do they transition?" I'm like, "No." And then she's like, "Well, he's not going to wear them." So then it's hard. It's like you're trying to tell a kid like this is better for you because of, everything going on in your situation. But then some parents I'm just telling do single vision like that regular for like sports and things too, because they're worried about like the peripheral blur for like activities like that. But then you just worry about the parent accidentally switching the glasses or the kid like going to one instead of the other. That's the hard thing about glasses, though. I feel like there's less compliance. I don't know. Then like Ortho K is like 100% compliance. That is on the cornea. 100%. A contact lens is on there until they take it out, so I always think about that with compliance. And like atropine, a lot of families that progress on atropine, when I actually get down and talking to them, they're like, yeah, we only use it like 50% of the nights because we forget. So it's like, is atropine less effective or is it just less compliant? There's so many things that you need to factor in. I actually had a 7-year-old boy last week or so that was a -50. And I was sitting here like, what should I do with him? But his mom is Plano. The dad is a -1. The dad says they don't even own an iPad. He doesn't do near work. And I'm like, we'll see you in 6 months.
Yeah.
Like he's a boy in the same class as my daughter. They're going to be crazy. If I try to give him a Stellus, like that thing's not even going to stay in his face. Like he doesn't notice it. He's not, like you said, Jason, he sees fine-ish. So I'm like, let's just monitor, talk about eye hygiene things, like being outside. And I trusted the dad. The dad was like, we're very strict on no screen time, so
what a good parent.
every kid, I know, I was like, go dad. Like
I trust myself to make Nora wear her glasses or like make sure that she's wearing Stellust over her single vision. So I know I can be that good of a parent and that committed.
So let's walk through some scenarios. Let's walk through some scenarios and say, and then we'll keep it in the low myopia range. So like 1.5 or below. Okay.
Right.
So you have a kid in your office right now who's, let's say they're 6 years old. There's a history of myopia in both parents, and the kid is a -0.5. Are you concerned about myopia progression? Do you have the discussion? Do you do anything right now? Or what's your follow-up time scale?
I would be concerned with the 2 parents. For that kid, I would probably start atropine and then follow up throughout the year. That's what I would do with history. And knowing that like 2 parents having myopia, even if it's like more moderate, it's higher and their biggest growth is going to be in that early age. That's my mindset.
And what strength atropine are you using? I
personally start out at 0.025 and then just see how they do.
Okay.
But I also have a more Caucasian population with like lighter eyes. So, the stronger ones are a little trickier. So it depends.
Okay. If the same kid was 5 years old and was a -1.25 and both parents were -10s, would you go to 0.05?
Yeah, probably. And I would probably.
Well, again, context matters a little bit, right?
Yeah.
Yeah.
You have to that's why everyone wants a clear-cut answer for myopia, and it's like, but it's not,
Yeah.
If the parents were comfortable, I'd probably do my sight for that kiddo because I don't trust him to wear glasses all day at school or daycare or whatever. But if the parents can get the contact lenses in the morning, that's what I would do with that kid.
You're talking about the higher.
Yeah, the -150. Like
what about the
put them in
-0.5?
glasses.
What about the -0.5?
Just to keep it simple, I probably would do 0.05 atropine, given the high myope parents. And at 6, and there was an article that I read that interviewed some myopia management gurus from across the world. It was on myopiaprofile.com. I love that website. And they had a 6-year-old or 7-year-old that was a -0.5, and they all agreed that it was fine to monitor for 3 to 6 months and check again, or that it was reasonable.
Yeah.
Reasonable. Depending on parent concern and lifestyle, I would either check in 3 months or start atropine 0.05%.
Okay. So let's stick with the 6 to 7-year-old age group with both parents being myopic, -0.5. But at what point with prescription, now I'm not talking age change, but I'm going to change their prescription. At what point do you go instead of atropine to something different? What point do you go to corrective lenses? At what prescription level? -1, 150, and then so let's say they're a -1.25 instead of 50, and they are complaining of distance blur. So now you need to give them corrective lenses. What are you reaching for at this stage?
6 to 7 years old.
-1.25. What are you going to put them in?
I would put them in, to be honest, I would talk about Ortho-K. I'm pretty bullish on Ortho-K if the kid's ready. I think that's a high enough amount where I can get good centration. especially with a small OZ and bumping up my Jessen factor a little bit. I feel like I can do it. Minus 150, minus 175 for me. I'm all in on Ortho-K. I feel totally good about that. Have a number of kiddos who are stable times multiple 3, 4, 5 years now at that starting point. Again, minus 1, minus 125. I would be fine with spectacle lenses. I would also be fine with Ortho-K, dependent on the patient's lifestyle. But Ortho-K would be introduced as an option to the parents.
Okay. Jamie?
I agree with that, Brooke. I probably start Ortho-K closer to like the 150-ish, but I would at least start them with glasses because they also just need glasses in general, especially if you're doing Ortho-K and if they ever need to not wear it for whatever reason. I don't like only putting a kid in Ortho-K and then if we ever have to discontinue for whatever reason, they're like, we never bought them glasses.
Right.
I think it's important for them to at least have glasses to start out with, and it's a good thing for them to learn how to take care of it. I don't know.
Well, if that patient is on atropine already, okay. So then in theory, being on atropine, they're getting round the clock myopia control, at least to a certain extent. Okay. If we're adding optical correction to atropine, if we're going to add glasses, soft lenses, or Ortho-K to atropine, okay? Because I think that's different than if they're not on atropine. Then if you're doing glasses or soft lenses, you're not getting 24 around the clock myopia control, only while their lenses are being worn. Where Ortho-K, you're getting 24/7. But if you're on atropine, you're already on a measure of myopia control, even when you're not wearing your corrective lenses. So let's say they're on atropine. At what makes you make the decision to put them in soft lenses or Ortho-K at 6 to 7 years old in that situation? Again, they're 1 1/4. They're not at a point where they're low enough that they don't need corrective lenses. They're at a point where they need corrective lenses. They need something. They need glasses, soft lenses, or Ortho-K, and they're on atropine already. Where do you go from there?
I would tell them they can do whatever they want if we're confident that they're not progressing. Like if they wanted soft lenses for sports, I don't know that we need to double dose, combination therapy. I don't think we need that until we know that they're progressing, because that's one of the benefits of atropine is being able to maintain whatever else they were doing if they were wearing soft torics or something like that. And you don't want to mess with it. You can keep them in atropine. So if they were 6 to 7 years old and, a symptomatic myope already on atropine, I would ask the parents what they want to do and do that.
So give them a little bit more, let it fit their lifestyle than rather than
single vision,
making them adapt the lifestyle of whatever treatment you put them in.
Yeah, I don't know that I would throw them in combination therapy until they prove it to me that they need it. It's kind of like glaucoma. You don't want to overtreat and you don't want to like wipe options off the table until you definitely know you need it.
So I'm going to throw something out there to that end. I referenced a study at GSLS that talked about efficacy of Ortho-K based upon the size of the red ring and the pupil size, and that Ortho-K is much more effective when the red ring falls inside the pupil diameter.
100%.
Okay. So if you're going to do Ortho-K, especially on a lower myope, wouldn't it be useful to have them be a millimeter larger pupils from atropine to get more of the confusion into their pupil? So what I'm saying is does it actually make more sense in some ways to put lower myopes who are in Ortho-K on atropine to actually make the Ortho-K more effective as well?
I think we can control the size pretty well without adding an extra thing that the parent has to do every single night and buy. I don't know. I always just think of it from a parent aspect. Like, I don't know. Like, I feel like I can control where the red ring is on my Ortho-K designs. I don't think I need them to be using atropine just to make your pupil bigger. But I get what you mean, but that's like combo therapy. I just don't think every kid needs that.
Thankfully young kids have bigger pupils too. Again, like if we're getting topographies that are, that are not in the pupil, then we can do that, like you said, to add in and enhance the effect of the Ortho-K lens. But I think in most young kids, we can get away without it, thankfully.
So we haven't talked a lot about soft lenses so far. At what point does the soft lens become the preferred option for a patient? Is it age related? Would if this patient, instead of being 6 or 7, was 13, would you go more for soft lenses than ortho-K? Is it a prescription thing, or or are you just not a fan of what's available? And if we had a lens that was high 6 times more breathable than what we have, would you be more apt to go? What would lead you to go to soft lenses? What could happen with soft lenses that would have you increasing your utilization of soft lenses?
I think they are launching MyDay in soon,
but it's not available yet.
But I honestly talk about all the options with the parent, and a lot of times it just comes down to lifestyle and what they think their kid's gonna want to do. Sometimes they don't want their kid wearing daytime contacts. Sometimes they absolutely don't want them sleeping in a contact. So honestly, it's just whatever is gonna work for the kid's lifestyle. And also, I don't know, soft lenses are a little harder for little tiny fingers and eyes to put in. I'm talking little, like 5, 6, 7. Once they get above once we're at like 8, 9, 10, I feel like they're both pretty easy for them to be able to do, but it depends.
Yeah. My concern, of course, has always been a low decay material for a child who's supposed to wear these things 7 days a week, 14 hours a day for the next how many years of their life while they're growing. A little concern there, but then also is how do you trust that 6-year-old to remember they're wearing soft lenses before they jump in their friend's swimming pool or before they rub their eye in the classroom and their lens pops out and now they're sitting there without any vision? That's always been the reason why I like ortho-K in the younger population, because everything with lenses happens at home.
Everything is controlled at home. That's why
Mom and dad do help them with it, and there's nothing to pop out during their day. There's nothing to get in an infection while they're off wearing their soft lenses during the day and they get into a bad environment. Again, the only downside is if it's a low prescription, does it help with myopia control enough? And that's another thing that we haven't really touched on, but if we had an ortho-K lens that could induce more blur even on a low prescription, then how much more would you utilize that? We've talked about how we wouldn't probably fit a -0.5 myope in ortho-K or a -1, but what if that -1 ortho-K lens could induce 4 diopters of blur?
Then I'd be all about it.
Yeah, that makes sense. Especially, it just gives us one more tool in the toolbox for patients and their parents.
So I think the good news is I think we can look at this and say, in the last year, Stellus has come out. There'll probably be another option for spectacles in the next year or two, which is awesome because again, a lot of kids just aren't meant for contact lenses, and maybe they don't like the atropine, and this is their answer. We should have had an FDA-approved version of atropine for myopia management, but that's gotten delayed. So hopefully, again, in the next year or two, we get atropine out there that is made pharmaceutical grade, not compounded, repeatable, same quality, every bottle out the door, atropine. And that's going to, again, help us feel more strongly about the consistency of atropine efficacy across our patient population. As you mentioned, we're probably going to get more soft lens options that have better materials and higher decay and healthier wear for kids. And I think, again, we need to push the GP manufacturers to better versions of ortho-K that can generate better blur and effectiveness even on our low prescription patients, so that we have increasing options for our patients, that not only we have options that work for patients more, but those options are better even than what we have now.
But how cool is it though that we have all these options? Because I didn't have any of them. I mean, none of us did. So, I mean, that's the cool thing, that we can have this whole discussion and we have so many options, and no matter what you pick, it's better than doing nothing. So that's the good news. No matter what you pick, you're doing something, and it's better than what we did in the past.
Yeah. But I think it's interesting too, though, that we all sit here and we say, what would you do with this? And we all kind of hum and haw, because it really is about the individual patient. And just like you say, it's like glaucoma. Yeah, we don't put all the same patients on the same glaucoma meds We don't treat them all the same. Part of it is how aggressive their glaucoma is. Some of it is how compliant they're going to be with meds as opposed to just doing a procedure.
Mm-hmm.
And so we have to get to know our patients. We have to get to know them. We have to get to know their lifestyle. We get to know their families. We have to understand their risk aversion level. Are they the type that don't seem to be bothered by the risk of myopia, but they're very bothered by the risk of wearing contacts,
Mm-hmm.
versus the one who's very bothered by the risk of myopia and could care less about any risk associated with contacts, or the whole spectrum. So getting to know our patients is critical, and then tailoring is the best way to go. And I know that not everybody out there that manages myopia is doing ortho-K. Some people are probably going, well, I can get by with MiSight and Stellest, and I'm just going to make do with what I have. I don't want to learn more about atropine and stuff. But the reality is, again, is if you're going to do right by your patient, you really should be knowledgeable and able to prescribe all 4 of those options, because some people will be better served with one of those 4. And if you're not offering all 4, again, you're maybe not serving your patient the best you can.
And you can always change modalities. Like I just had that talk with a little girl I've seen, and she's been in ortho-K for 3 years, and she was acting kind of, like she wanted to tell me something. And then her mom's like, she just kind of she wants to wear glasses again. And I'm like, that's okay. Yeah. I said, it doesn't hurt my feelings. Like that. I think she felt like she was like letting me down because she's like, been doing it. And I'm like, that's okay. We can do, now we have Stellas, we can go to that. And then if she changes her mind, because she's older now, she can change her mind and she wants soft contacts, we can do that too. Like, it doesn't have to be, they started this when they're 7 and that's the modality for the next 10 years. Right. Change with them. And so it's funny. I'm like, honey, I'm not mad at you.
I know. It takes a lot to hurt our feelings after this.
Right.
I was like, if you don't want to wear these overnight anymore, that's totally fine. Like we can go back. She's like, I just like accessorizing. I'm like, whatever. Like, you know how little girls are, but it's fine. You don't have to be married to one treatment.
Yeah.
Exactly. Well, I think again, we could probably spend another episode talking about myopia control for other types of patients. We didn't even really touch on axial length and that risk and whatnot. So maybe a future episode we can get into more of the higher myopes and assessing risk level. And I think we also have a little disagreement maybe, or lack of agreement on combo therapy, which we could talk more combo therapy and the pros and cons of that. So future episode, another episode on myopia management still to come, it sounds like. Any parting shots for us, anybody?
No, I'd love to hear in the comments though if people disagree with us or agree with us, or what are you doing? Right. Let us
agree. I would love to know.
Maybe we're all completely wrong, or maybe you you love our.
Who's out there fitting -1/2 in ortho-K? I want to hear about it.
Right. Yeah, and again, like you said, Brooke, maybe someone's out there saying, "Yeah, I do that all the time. I just ramp up their Jessen factor."
Yeah,
and,
let's hear it.
But then again, I say, well, so what you're really saying is you're overcorrecting that patient by a diopter and a half, making them a 150 hyper open. I'm not sure that's any better than having a little bit of myopia either. So
well.
Anyway,
I'm sure they would love the opportunity to hear Jason tell them they're wrong.
All right, you guys know how to get a hold of us. Hopefully you do by now. It's on Instagram. There's one page. Gmail, email us. We do have Facebook also. As always, send us cases. If you have a case, send it to us. If you don't have a case, just a comment. That works too. But get in touch with us. We want to hear from you. Feel free to critique me. It's all good. Until the next time.
Sort of.
See you guys in my DMs.
All right, everybody. We'll see you next week.
All righty. Bye.
Bye.